face. Now I welcome Dr. Rishith Tiwari. He is the director of Tiwari Eye Hospital at Noida, and he is a prolific vitreoretina surgeon, and he'll be sharing his experiences with few rarer macular disorder. He is filling up for Dr. Vipin Rana from PGI, who could not be present today. Thank you so much, sir.
Yeah. Good morning, everyone. Thank you, Colonel Pradeep, for giving me this opportunity. Uh, so this is not my presentation per se. This is someone else's presentation, but these are very interesting cases. So, and because of want of time, I would want to rush through the cases just to show what uh, is important in these cases. So the acknowledgements are from faculty of PGI. The first case is a 39-year-old Asian male. He presented with chief complaints of decrease in vision in his left eye for 15 days. It was insidious, gradual onset, painless, associated with metamorphopsia. Now, patient had already been treated with the intravitreal injection outside for a possible diagnosis of a CNVM in the right eye and no treatment in the left eye. So these are ultra wide field images of the right eye. Vision is finger counting at this time. So what we see here is a whitish yellowish structure in the macular region, which is visible, and the surrounding pigmentary changes along with it. Now this is a clear-cut case of a CNVM. What is missed in this image is these black lines, which is starting from the optic disc and emanating radially outwards, and these black lines are seen elsewhere as well. And once we move to the a higher imaging, we see that in the enlarged image these black lines are even more visible. So the patient does have a CNVM, there's no doubt about it. When we look at the other eye, again a similar picture is visible. Black lines emanating from the optic disc and going radially outside. The left eye also shows some pigmentary changes. So there is CNV, but the basic diagnosis changes. The patient has angioid streaks, and that is why the patient had bilateral CNV at a young age. So fundus autofluorescence shows us pigmentary changes in the posterior pole in both the eyes. Also, the peripheral drusens are now identified as a marker for angioid streaks. So patients who have peripheral drusens, they tend to have complications of angioid streaks as well. So an OCT angiogram was performed, which shows a well demarcated membrane complex in the right eye. Now all the vessels are dilated, so there's no activity there. On the other hand, in the left eye we can see that there is an active membrane complex and along with subretinal fluid. So patient had already received treatment for the right eye. It was stopped because there was no activity, but there was decrease in vision in the left eye, and the patient required anti-VEGF treatment for the left eye. After 3 monthly doses of anti-VEGF, we see that the BVN is now almost gone. There's no subretinal fluid, and the patient's vision has improved. BCV is 6.9 at this point. So the second case is a 12-year-old female patient, decreased vision in right eye, noticed 2 months back when she closed her left eye. So this happens very frequently with kids. No history of redness, pain, watering. She was diagnosed as idiopathic CNV and advised anti-VEGF injections. She did not have any systemic history. This is the fundus image from that time. BCV again is counting finger at 1 meter. The fundus picture shows a whitish lesion just superior to the fovea. Now this is a subretinal lesion. Blood vessels can be seen going above it, and then there is a lot of pigmentary change in the foveal region. Left eye is absolutely perfect. Vision is 6.6. So a swept source OCT was performed, which showed something in the choroid. Now this is not a very normal picture. This is a well demarcated structure which is visible in the choroid, and if you look temporal or nasal to it, you can see the normal vascular structures of the choroid, but something has happened in this area, and there is subretinal hyperreflective material in the subretinal region. So two distinct structures were visible. One is these lamellar lines, the white lines that are visible, they're stacked as a lamella, and second were these black channel like structures. So this was not a normal picture. This was not a normal presentation. A vertical scan through the lesion showed a whitish membrane complex which was already there. The foveal region was looking more or less okay. So this main membrane complex was actually away from the fovea. These are offset scans. But the choroid beneath was not normal. As we go along the scans, we see that a large area is being encompassed by this entire thing, by this entire complex, the membrane complex and the other structure. So on performing an angiogram, what we found was hypofluorescence in the early phases, then a membrane complex appearing, and a patchy hyperfluorescence later on. The other eye was absolutely normal. A swept OCT revealed a branch vascular network complex. An ultrasound was done to localize through that lesion to see what was happening, and what we found were supramaximal spikes going off the charts, which suggested the diagnosis of a choroidal osteoma. So the patient had a choroidal osteoma, she had a CNVM. So in a 12-year-old kid, if you have a CNVM, it cannot be idiopathic therapy. It is very unlikely to be idiopathic, so we have to look for other causes. So problem, and there are a lot of DDs, so depending upon the age of the patient, depending upon the clinical picture, and using multimodality imaging, it becomes easy to distinguish between these two entities. Now CNV had to be treated, so patient was given intravitreal ranibizumab. Now this case presents a twofold problem. There is a CNVM which is easy to treat, multiple repeated anti-VEGF injections, but the other problem was the choroidal osteoma component, which if reaches the fovea can lead to further vision loss. So for that, ablative laser photocoagulation or photodynamic therapy can be tried. So again, as I explained, it's a twofold problem, and we need to treat both the CNV and the basic underlying problem in this particular case. So choroidal, these are some publications regarding what the picture of the choroidal osteoma was. So there are two separate entities that were visible. The white lines were actually the bony lamellae, along with vascular channels which appeared hyporeflective on the OCT. So these black regions are the vascular lamellae between the bony structures, between the hyperreflective stacked lines that are visible on the OCT. And the third case is a 50-year-old male. He presented with chief complaints of decrease in vision, bilateral, right more than left, insidious gradual onset, painless, and there was some metamorphopsia. There was no history of floaters, flashes, glare, or double vision, no significant past history, non-smoker. Patient had received 2 anti-VEGF injections, which did not show any response. So this, the BCVA was 6/24 in the right eye, 6/12 in the left eye. The anterior segment was absolutely normal. The posterior segment showed this. Now, this is the right eye, this is the left eye. I think after Colonel Raji's presentation, things would become much clear what we are going to talk about here. So, 2 DDs as can come to our mind. One is AOFVD, adult onset foveomacular vitelliform degeneration, or a CNVM. Again, autofluorescence showed hyperreflective, hyperautofluorescent dots in the parafoveal region. Left eye disease is not that prominent in right now, and the OCT shows us neurosensitive detachment, lot of Schrem, but there's no membrane complex that is visible, at least in the OCT right now, even in the right eye or in the left eye. So this is the left eye where the disease has just started to come up. So angiography was done, which showed delayed pooling of dye and hyperreflective and these hyperfluorescent dots. Left eye, it's a very early disease as of now, so only few areas of patchy hyperfluorescence is visible. In the later phases, it encompasses a little more area compared to the initial frames. OCT angiography did not reveal any membrane complex. And if you do an EOG, you get to the diagnosis of AOFVD. So no treatment of anti-VEGF. Patients, best part is that the patient's visual acuity remains more or less stable in these cases, and only observation is required. So not all membranes are, not all the things that look like membranes are actually membranes. I think a lot has been discussed about AOFVD. We may not go through these slides.